Hello,
Hello.
everyone.
Oh, getting cold now.
It's getting windier, that's for sure.
Yeah, the rain seems to stop, but the wind is quite strong.
Yeah, same here. We've just had kind of average rain all day, but the wind's decided to really start to get gusty in the last 2 hours.
Yeah, I saw the news. They said that Auckland is pretty damaged.
Oh yeah. I think at the moment, just over in Gisborne and Hawke's Bay is pretty
Oh yeah,
pretty horrific.
there's no power there.
Yeah, and I think they're in a bit of a communication black zone at the moment. So I don't think we're seeing half of the stuff that's happening over there. That's for sure. But yeah, some of the stuff in the Hawke's Bay, like that Esk Valley, like the winery,
Yeah,
is just completely. I saw it one year.
You've lost
And
Mary. Oh, you're back.
I can hear you. I can hear me. Yeah, and that she was swimming out her window at 4 a.m. to get out of it. Just like, whoa,
I can't swim.
you can't swim.
Yeah, I don't know how to swim. Yeah, that's a big problem.
Do you live on
Oh,
do you live on a multi-story house then, Ten?
Yeah.
Yeah, good. Go upstairs.
yeah.
Yeah.
Definitely a skill worth picking up,
Yeah, I
even as
think
an
so.
adult.
Yeah,
Oh,
I forced
yeah.
my daughter to learn it,
Yeah.
Yeah,
and
that's
I
so
don't
funny.
know.
When I was a kid, my mum made me go to gymnastics, like sort of somewhere between 5 and 10, because she remembered when she was at school, they made them do like gymnastics at school, and she couldn't
Yep.
do it, and she was so embarrassed, so she made me do gymnastics. And then for the swimming thing, like what you said, Mary, she was like, "Oh no, you have to learn how to swim." Then I had to
Yeah.
do swimming. It's like
Yep.
some of
Yeah.
like parents are like, "You have to do these things because they are essential life skills."
Yeah.
Okay,
Yeah.
right.
Well, that's the thing, because my folks wouldn't be able to swim. My siblings can probably beach swim. I'm the only one who can actually swim, and it's because
Yeah.
of the enforced lessons as a child. And
Yeah, funny.
We're beach people, so it was important for our
Yeah.
children to be able to swim.
Mhm.
So
Yeah.
you get out there in the boogie board and you roll around those
Yeah.
waves.
Well, it's funny when we were over in Vietnam, we went to Halong Bay, and Waitalong Bay, and one of the parts was you go out, you stay the night, but you can go and swim off the boat and dive off the boat, and naturally, me and Matt just jumped, and there was a whole heap of people that they'd never really been in water before. Some of them were from the middle of India or places that didn't really have access to, that we do to large areas of water, and they were just absolutely petrified with their life jackets, just hopping into the water just to float. And we're just like swimming around and having a good old time, but forgetting that, like, when you're not brought up in an aquatic country, it's not really part of your upbringing.
It
So
still blows my
no.
mind that there's people that have never seen an ocean,
Mm.
like especially in the
Yeah.
States. It seems to be like that Midwest chunk
Yep.
of the States. They're like, oh no, we've never seen the ocean. I've never been to a beach. Like, I've never been to a beach. I was
Yeah.
just reading. So we got the HPV vaccination,
Oh, yep.
parent
Oh, yeah.
consent form.
Oh,
I
you
was just
got that?
reading.
Yeah,
What?
yeah. I remember getting that for Connor.
Yeah.
Yeah.
Yeah, so just reading through what actually is it that I'm consenting to beyond the jab, which is what it very much focuses on. But it's very light, apart from like one little bit that I found in small print on the back that tells you actually what happens with your child's information.
This will get stored in the NIR.
Quite interesting. I might bring it in for Ben. Like, there you go, Ben. There's a current example of how we do it.
Pour over this.
Paper
Yeah.
form.
It's I thought so. I've seen a few of those as Connor's kind of been vaccinated.
Yeah.
And none of it's particularly compelling material. Yeah, it's all very bureaucratic kind of content.
Yes.
You know what I mean? So you sit around and you think, oh, I wish it was more. I wish it could be more engaging as content. Like for the kids. Why would tell the kids why they want to do it? Tell the parents why they want to do it. Separate. Because the kids might have different motivations from the parents, especially when they get to kind of. I'm guessing Abby's age. Is it Abby getting vaccinated?
Yeah. Year 8. Yeah. She had one last year. I forgot they do too.
Yeah. But I think that's kind of the interesting thing to me is like we talk a lot about self-determination type stuff, and like it feels as if they've given you this piece of paper to take home, And what is this jab? I don't know.
It literally came out bag and they were like, you need to fill this form in so I can take it back to school. Like that's the instructions.
Yeah. But what's in the form? No idea. They just told me that you had to fill it out. Yeah. So yeah, interesting stuff. I thought maybe this time we could talk about the Therapeutic Products Bill, like, because it's on our list of things to presumably provide feedback on. And I've thought about it a little bit, but I haven't thought about it a lot. And when we talked about the long-term insights briefing, Richard, I don't know if you saw that come out of the ministry before Christmas, long-term insights briefing into personalized health. Is that what it was?
Precision health.
Precision health. Did you see that come out? Oh, you're on mute.
Yeah, sorry for turning up on mute. Yeah, that looks really interesting. I kind of found out ESR were putting something in and it's quite genomics heavy, but there's heaps of opportunities.
Yeah, totally. Well, the fascinating thing for us, I think, in that long-term insights briefing was it was 10 years. So it's not short to medium term. And it was that Bill Gates said we tend to overestimate what we can do in 1 to 2 years and underestimate what happens in 10 years. So you've kind of got this, from a technology perspective, that's 3 full cycles of technology. You know, imagine 10 years ago, 2012, the year after the iPad came out. You know, isn't that interesting? Like, and imagine, like, we then went through tablet mania, where like you buy all sorts of Android tablets, and now you can't hardly buy them. You know, there aren't that many, but now we've got Microsoft Surface. The iPad still goes, and now we've got folding screens. Like, and so things have moved quite a lot in that 10 years. You know, like in terms of the state of the art.
Yes.
So yeah, it's an interesting kind of thought that they've chosen a 10-year horizon. I suppose. I don't know if that's legislated for, Eileen. You know?
Yeah, no. Normally, long-term plans is 10-year planning. Cycles.
Yeah.
Not that we do it in government particularly well.
Yeah.
But yeah, ideally.
So yeah, so we provided feedback, and there's just so much in there. Like in terms of, so you might do the genomics now, Richard, but then you know what happens in 10 years with it once you've had it for 10 years, kind of question, and second or third generation of having genomic data available. So I was talking to Stephen Robertson just before Christmas, who some of you might know, who works at genomics in the Genomics Aotearoa program. He's got 600 of 1,000 genomes of Māori people in New Zealand who have given their genomes for research to create a Māori variome. And so, you know, at the end of this year, we're going to have a Māori variome. What might that mean for the next 10 years if we've got it? You know, we'll sit on it for 10 years and do nothing. Like, that might be something we choose to do, but, you know, it feels like we could do a lot in 10 years, you know. What else did we put in that long-term insights briefing?
I thought, I mean, they had pharmacogenomics, and I thought it was interesting that they put digital health in there, because it's kind of like they felt, well, digital feels like a thing, we should definitely include it, but without really, like, because digital health's been around for a while. It's like it's not a new thing in terms of it being widely used across the current health system. So for me, it would be interesting to kind of go, what do they mean when they say digital health? Like, what was their kind of thought when they put that down as a category?
I don't know. And maybe it was just a product of a Google search, and you're like, oh, precision health. Let's come up with the topics, and we'll bung them in, and we'll let people tell us what they think. So our imaginations ran wild a little bit. I think I've got the document here, but there's definitely a lot of stuff that you could think in 10 years' time, where would we be? I feel like we're one of the few groups in Te Whatu Ora that's actually put something in, which, you know, you might have expected us to put something in. So yeah. Potential risk with precision health advancements are highlighted below. Health insurance companies misusing individuals' data, pathway to eugenics or design of babies, in brackets Gattaca. So we got that far. And then human robot cyborgs. So we got that far too. So not just genomic tinkering, but also, you know, human machine interface tinkering. So there was that article, was it over Christmas, New Year, where they'd put in the latest version of a human brain interface into a woman. I thought I read a story about that over Christmas, maybe. I don't know if anyone else did. So it's coming, definitely coming. Neural lace, I think, is the...
Our friend Elon tinkering with monkeys at the moment.
Yeah, but there's limited versions that are kind of going on in clinical trials at the moment, so around the world where they're doing implants, but obviously the resolution of some of it's really, really low. I think, what were they trying to do? Retrain speech, maybe? Definitely read something recently about it. Fallen out of my head. So I think the interesting thing is there's a whole lot of impacts as a consequence. And your one, Eileen, was the most interesting one, I think, which was we tend to think in like, we'll make a change to this part of the process without realizing the ripple effects that kind of that substitution makes. And I think about the drone kind of conversation when you talk about this, and you're like, oh, a drone will replace, motorbikes driving from a clinic to a lab. And yeah, but at the same time, you need CAA to approve it, so the flight corridors. You then need people to maintain and manage the drones, which is a very different job to driving a motorbike. And then you start to ask that question about, well, if we can get things from point A to point B really quickly and reliably, what else would you then transport? And suddenly, there's a bunch of stuff we probably do transport or don't transport because it's too hard. Like I was thinking then with the IKEA Faster thing, would it, and I've seen some of this around what are the things that you have when your heart stops? Pacemaker. What are they called? The one.
Oh, the other
gives
one.
You the,
yes.
They use drones to deliver those. Yeah, those things. Whatever words fail me. Whatever that thing is. So they
defib.
Defib, that's the word. So they deliver a defib on a drone. I was thinking maybe we should deliver troponin T testing on a drone. There you go, Ben. Stage 15 of the IKEA Faster project. So yes, so the long-term insights briefing, definitely an interesting kind of question being 10 years in advance. I don't know, Justin, if you'd seen that come out of the ministry. Did you see that come out? No. So wanting precision health, precision medicine guidance or ideas about what it might look like in 10 years' time. Yeah. I know, what do you think healthcare will look like in 10 years' time? Yeah, what do you reckon? Anything off the top of your head? You're on mute, so you'll have to unmute yourself.
It's not exactly the fastest sector to change, so what are we seeing? Yeah, I mean, Spotify, the guys that founded Spotify have set up basically War on a Fitness startup. If that kicks off with their $30 million of investment using precision AI,
yeah,
that type of thing could, get around the world like wildfire if it's effective and means that each of us can get an early detection of things that are using smart diagnostic technologies. I think moving away from big hospitals is obviously something that has been talked about for some time. I still think that will be the case, that we want healthcare closer to home.
Could you imagine like a box that gets delivered to your front? You know how you get the meals delivered in cardboard boxes every Sunday or whatever it is these days. I can imagine like a hospital in a box. Literally, like the courier turns up with a bunch of stuff when you're sick. You start unpacking it, an oxygen mask and whatever.
We could all have a beta.
Whatever else has got in it.
All have a Betamax from Big Hero 6.
Your
friendly healthcare assistant.
I just thought about
I go back to I go back to the ITIL service menu sort of view where you have a generalist and a specialist, and it's a constant flow of specialist things becoming more generalist.
Yeah.
And if I think of the example that my grandparents gave me, that when they got a loan from their bank 75 years ago, the bank manager came out, climbed under the house, and checked the piles. These days you go to get a loan, it's some kid straight out of university, because all of the risk evaluation has been done by an actuary who probably isn't even based in New Zealand, and it's all in the software. And so that university graduate is being measured on number of sales of credit cards and home loans. So I would expect that certainly on the GP front, I think the GP role is going to look fundamentally different. They just aren't, the workforce isn't there. The demand is too great. We just can't keep that model in place. It's going to have to give. And too much information. I read an article that if a GP would just to read all the latest medical publications that they should to stay abreast of and care delivery or what have you, or best practice, I think they'd have to read for 36 hours a day. There are only 24 hours in a day. So it's just that the business model just doesn't work. So I would expect to see GPs will be on the front line of that change. As I say, with Spotify getting that $30 million, well, it's not Spotify, it's the founders of Spotify, $30 million to set up effectively what is a Warren of Fitness, using AI, smart diagnostics and smarts. That's really interesting. So
yeah, we're interested in that. So we're interested in that. Can you so you try to then pick off big segments of kind of doing that Warren of Fitness thing, and the biggest one I can think of is cardiovascular risk assessment. So I've got a current state user journey up on the Glass, which has been up since second week of Feb. It's been up about 4 weeks now. Taken a bunch of people through it to go through the gain and pain points in that journey, and I tell you what, it's unreal how many there are. So you just look at the whole fact that we invite people to get a cardiovascular risk assessment. So even if you know you're at risk because of your personal circumstances, there's no way you can get access to that service. We'd rather you go through a more convoluted, complex model than you serve yourself. But at the same time, we've then got people that aren't even being served. So
what's involved in doing the risk? Is it like a questionnaire, or is it a set of blood tests? Or
so it's a lifestyle questionnaire. It's a blood pressure measurement. So you do a blood pressure measurement. So you go into the clinic and you do the questionnaire with the nurse, and you lie to the nurse about how much you drink and whether you smoke still and how often you eat Burger King. And then they do your blood pressure, and because you've just run in because you were late because you couldn't find a car park, your blood pressure's through the roof. And then they give you a piece of paper to go away and get a blood test, which you never get. And so completion rates are somewhere between 50 and 75%. It's about 50 for Māori percent, about 75% for other. And the second leading cause of turning up in an emergency department is chest pain. So, which Mary and Ben have been working on, and I think we've talked about before. But so blood test, blood pressure measurement, and a lifestyle questionnaire. There is some evidence that you can use a photo of the back of your eye to measure not just diabetic retinopathy, but also cardiovascular risk. So
yes.
Is just getting a photo of the back of your eye the fastest method for us to do that process? Maybe it is. So
to explore that. Another question. Oh, sorry, you go, Justin.
Oh no, I was just going to say, I mean, that's a really good example, John. And there was I saw something come through my social media feed where a woman noticed that her husband started to smell different 11 years before he was detected with he was diagnosed with Parkinson's. Turns out she can smell Parkinson's.
Yep.
So they've taken her ability to smell it, worked out what the molecules are that trigger the response, turned it into a swab that's now 95% effective. They just swabbed the back of a person's neck. Which is extraordinary for Parkinson's because there's no reliable diagnostic. So on top of the things that we kind of know about, and we know that they don't work like the cardiovascular assessment, there is that new stuff coming out where you're just going, holy moly, that's extraordinary.
Yeah, because in the clinical trials, she had the different test groups, and there was someone, she's like, no, this person all have Parkinson's. They're like, no, that's the one you got wrong. And about 2 years later, his diagnosis came through. So she was that good.
Oh, wow. I didn't know that.
Yeah. That's even better. She broke the test.
And ants can detect, because there was a movement for training dogs to detect cancer. And then they discovered that ants can do it faster.
How do you train an ant, though? Do they run away from it?
I have no idea how they train them, but they work it out it doesn't take months of training.
You breathe on them or something.
Do you have to put them in your ear or something? Like you put them in your ear or down your throat or something? I don't know.
Oh, why would you do that?
Well, how does it find it? How does it find it?
Yeah.
It's to be inside you.
One of the challenges is there is so much on, just appearing every day in in the research field, or like new people developing new products. It's like how do you as a system prioritize or investigate, like where do you put your effort? And I don't think we're very good at doing that at landing, and like these are the things we need to go after for years 1 to 5 for these reasons, and just get them into the system.
I think
probably because there's always more things coming, so you're always constantly distracted by this new shiny stuff always coming. But then some of the stuff's not that easy because, and we've talked about before, I think, about the timing kind of thing, in terms of need the people and the problem and the technology to kind of all be together at once. People willing to solve the problem being real, and some technology in the right place at the right time to support it. Like that, turns out that's harder than you think, because those people don't just worry about that one problem. They've presumably got lots of problems that they're interested in. So, yeah, I think that's the issue, is apart from being always bombarded with new things, or things that are masquerading as new that aren't as well. I got an invite to a meeting today. Hey, there's this new thing, and I'm like, yeah, met those people in 2018 and talked to them last year as well, and still doing the same thing. So it's not new. Might be new to you, definitely not new to us. And here's something here's some things you might want to think about with regard to that. But
yeah, there was a hospital in the US who's I can't remember which, it might have been a Seattle Children's or one of those, but when you looked at their mission statement or what have you, it was something along the lines of being the best at being better. So picking up on that idea of there's always stuff coming out. So don't set some goal around diabetes or whatever it is. Actually just set a goal of actually just being really quick, either quick to adopt, quick to adapt, or quick to invent, but just pick which one you're going to be really good at,
and get on with it.
I think there's some merit in that.
Do you worry, Justin, that you run into the problem of polishing a turd kind of problem? Do you know what I mean? Like that it's so broke. Like for the GP thing, it's so broken. Making a GP 1% more efficient every year is not, still not going to have time to read the content they need to read, let alone deliver the care. Do you get caught in that if you're worried about just being better again tomorrow?
Yeah, maybe. I guess. The way that we solved it in Auckland is that we now have the improvement team who work on the near term optimization, get a 1% gain. There's lots of Kaizen fans out there who will say 1% gain every year is gold. And then we've got an innovation team who are looking for the disruptive. It'll be different. Maybe you might not make the decision right every time. You might try and innovate in a space where you were better off optimizing, and you might try and optimize a space where you were better off innovating. You can't really know. You can have some kind of gauges, some ideas about how to assess and triage which way you want to go, but it's certainly not a perfect science. I keep getting asked about my prioritization matrices for Ara Manawa. How do you choose what projects to work on, Justin? Well,
experience.
Yeah.
Having a good understanding of how well defined the problem is, knowing that there are people that are wanting to work on it, and then having some ideas. And then as soon as you get on to having all of those things, suddenly it kind of starts to click, like people get excited about it and they want to do something. And at that point, you could spend a whole lot of time waiting to try and get all of those things, so we've had this problem for years and we've never been able to solve it. Well, is that because no one's got any ideas, or because no one cares about it, or because, it can't be solved? I don't know. And it's an interesting thing, because I get asked exactly the same question. And the answer is, well, you find out pretty quickly if it will move or not. And often it's not. Me giving it some attention gives it a little bit of impetus, but I'm not the person that makes it happen. Do you know what I mean? I'm almost just a signposter to go, hey, if you're doing that thing, you do it in this way, or talk to these people, or have you thought about these things? And it's really off the back of other people, not me, that make things successful, if you know what I mean. Or you couldn't have had IKFS, or I would say Ben, without Martin. Like, it wouldn't have even been on anyone's radar. Do you know what I mean? Like, if he hadn't gone out and got the money from HRC, which slightly annoying to us that he just went and did that without actually getting any money for us.
Different problem.
But do you know what I mean? Like, if he hadn't done that, we couldn't have helped them. Interesting question about what you would have been spending your time on if you weren't doing it.
And how much less stressed you'd be.
Yeah. He doesn't look stressed at all. He's not trying to do two things at once.
Multitask.
How are you, Sally? We haven't seen you in a wee while. Did you have a good Christmas and break and all of that sort of stuff? Are you back at work?
I've been back at work since the 9th of January, but we flooded twice. And,
oh no.
And then I didn't sleep much last night, so thanks to the storm.
Worried about
that. Oh, it was more the wind, and there's a tree that's outside above my bedroom window that last big storm, the last one next to it, fell down. It's a humongous gum. So I'm always worried it's going to fall. No, all good. Other than that,
ring the council. Ring the council. Ring the council. Tell them it's
trouble is, it's half on the council land and half on mine. And
sounds
I'm
like it's a council problem to me. Do you want free
but
firewood?
they won't do anything about it unless it falls on the road. So I need to get it to fall on the road, not on my house. Don't quite know how to do that though. You have to excuse me. No, I've been a bit tied up with work. Work's just been a bit nightmarish.
I'm sure it'll come good.
It should do. It should do once I finish the 164 from last year. That is still coming. I know.
End of year marking, is it?
Well, no, it's just been pushed to February because this is the cohort that went to the media and did a few other things. So the grades got left. So I'm just finishing off the stragglers.
Lucky you.
Yeah, it's all right. Could be worse, I guess.
Yeah, indeed.
But I'm not doing anything exciting right now.
No. Have you seen anything exciting on the internet, Mary, in the last couple of weeks?
I have. Apologies, my internet's a bit crap at the moment, so I may cut out. What did I spot? So over in Aussie, they're trialing a remote patient device, which is a reusable patch-based ECG sensor. So it provides a convenient alternative to the good old traditional Holter monitors for ambulatory monitors. So it's what's it got? So the data is sent by Bluetooth and synchronized with a mobile app, allowing the patient to diarise their condition on their phone instead. So you can wear it up to 72 hours without changing the battery, and then observe the ECG waves and log the symptoms using the app at the same time. And so then there's a cloud-based portal, allows the clinicians to view, edit and diagnose the patient's ECG at any location, and an AI-driven ECG analysis is provided as an easy-to-read report. So I thought that was
sounds amazing. Good. But is that a bit like the bio button that got tried here in South Canterbury and in counties? Do you think? Like, because that's like monitored kind of
opinion.
Heart signs.
Maybe.
So maybe similar.
But yeah, I don't know if the Apple Watches do ECGs, or at least 3 leads anyway.
Yeah. Yeah, having had to wear a Holter for a week before, I know how cumbersome and horrifically annoying they are. So anything smaller than that is good in my books.
So is the patch itself a wireless patch or something? Is it?
Yeah.
Bluetooth. Yeah.
Which is pretty cool. What else we got? Somehow it came up. This came up on Pulse. I don't know which one was it. That one there. This one came up on Politico. It was a doctor's lament buried in data. So doctors are suffering from data overload, saying that more than 7 in 10 say they have more data than they can handle, and this is becoming increasingly larger now that with the introduction of apps and wearables sending data to providers, and that they just really don't know what to do with all the facts and figures that come from health trackers and provider networks and EHRs. So I thought that was quite interesting. They surveyed 1,000 GPs around the world, 500 in the States and 100 from other countries, and just gave a bit of an overview on that. They often don't understand the standards or protocols to help them make sense of it all. And
it's interesting. I was in Christchurch yesterday talking to the Health One team about the too much data problem. So they part of Health One is collecting observations, and I relayed to them. So probably about 10 years ago, there was this decision made that we should be sending all the stuff from the hospital out to the GPs. So because you couldn't have a shared record between the hospital and primary care, we'll just send primary care a bunch of copies of everything we do in the hospital. And so that was lab tests and clinic letters and discharge summaries and basically everything you produce out of a hospital. And I remember going to see, it must have been like January 2020, because we'd just built version 2 of MyMeds to do some testing with consumers. And we're going out to talk to a GP practice in Upper Hutt Health Centre, I think, about, you know, do they have some patients that would want to try it? And he said, yeah, they can try that. But hey, I've got this bigger problem. Our inbox there, so their GP inbox for their practice, so it was a big practice. Said they got 10,000 items a day into their GP inbox. And so it takes 36 hours, it turns out, Justin, to read all the information you need to read in order to stay up to current practice. And then you have to get onto the 10,000 items that come in your inbox every morning to know about, you know, the state of your patients and how that's changed before you can even start work.
Yeah, well, there you go. That's just untenable, right? That's put it through totally. Chat GPT. I don't know. Like, honestly, that is untenable.
Did they not do any like rationalization of data and like pre-populating fields within the, like, what would a GP need to know at any given point if they had the patient in front of them?
I think that's a good question. The reason and the reason I know it started happening in the Wellington region about 10 years ago was there was a case where someone had gone to the emergency department with like a pneumonia or something like that, like chest infection of some description. So they got I want to say they got a chest X-ray, and there was an incidental finding of a node in the chest X-ray, and so therefore, by the time the person had gone home from ED, that incidental finding got reported afterwards, and the GP was in trouble because they didn't review the chest X-ray, even though they never got the report. So because the report was done in the ED and stored in the hospital, because there was no one left from the emergency department to look at it. So that led to us going, oh crap, we'd better send out everything to make sure that the GP knows about it, so therefore they can take responsibility for all of the things that are incidental findings. Because that's the tricky thing in a hospital, you know, and you'll know this, Justin, that a house surgeon orders the bloods because they're cross-covering, and so are on a ward round, and it turns out they then leave and they aren't there the next day, you know, for the patient to review the bloods come back. You know, you'll know about that too, Sally, from an ED perspective. You know, the person that orders isn't necessarily the person that needs to know the result. So, and I think being an eye care faster, this is what Martin was saying, there's more benefit in eye care faster than just the time for the test, because you've then got these synchronization issues for the clinician, which is, I'm not going to go and sit and wait for the test result to come in because I can go and do other stuff. So in that doing other stuff time, you know, I can go and see more patients. And so then if I miss that window, I've missed the window, and I'll come back to it when I come back to it. So the patient just sits there even longer.
I used to spend half my time checking on all of my patients' results to see if they're back, and it was annoying. I didn't order them. I might order the odd X-ray or the odd full blood count, but ended up checking on all the docs ones just to push them along because they're doing exactly what you were saying, John.
Yeah.
Excuse me.
Yeah, there's definitely something in that notification space, in terms of being able to, and this is the tricky, so talking to Health One yesterday, they show everything. So they show all of the data. Then they said, and we show prescriptions from the GP, then we show dispensing from, and they get it directly from the pharmacies, not through the prescribing service. And we don't do any smart matching, we just show the list. And I'm kind of like, I mean, that's good because it doesn't presuppose anything, but it also just creates a massive overhead in terms of trying to match those two things together. It's like, you've given me all of the data and none of the intelligence that I need. So super frustrating. But how do you guys do notifications in Auckland Hospital, Justin? Like, have you got like the smart page or something like that now? Or are you still running pages?
No, we were running, I can't remember what the tool is that we're replacing our pages with. There was some concern about one of the code protocols not being accommodated well by it, and so we were going to do some design work for them, but I think they managed to resolve it with the vendor and their designers. I can't remember, sorry, John. But I would say in principle, we don't have a good mechanism for organizing work such that it's mostly a pull system. So you can draw down the next job rather than having stuff pushed at you that you're filtering through to say, is this ready for me now? And I think I've shared previously with the example of a physio having a list of patients, going to see the patient that, they've just walked effectively a kilometre from one end of the hospital to the next, and they turn up and the patient hasn't been toileted yet, so they're not ready, so they go off to their next job. The kilometres and the time wasted and the experiential failure for the patient because it looks like we don't know what we're doing. To my mind, a long haul flight is the best analogy that I can think of. That flying to New York in one go will be an entirely scripted affair in terms of when the lights get dimmed, when you get served a meal, the illusion of choice or that sense of control when it comes to picking a movie and your little airflow thing. All of that stuff we should be giving to patients, including this is when else I want to see the physio. And I'm ready now to see the physio, and then the physio gets a little buzz to their app that says,
I totally remember that being a physio. The number of times you'd go to see a patient and it was literally the ward round was in the way, or like the nurse was busy doing medication, or they had visitors, or like, and of course it all evened out because then you ran around the ward to try and find someone else that was available that you knew was on your list, but you hadn't planned to do them now. So you're busy trying to juggle that all day long, and that was painful.
Yeah, so I think just coming back to why we're here for the patient. Let's organise, what's of value to the patient. Let's organise it around the patient, and then everything else will flow. And we just don't have that mechanism. So if we could come back to basics and just what does the patient need? Let's bring it back to the patient. What does the patient value? Let's bring it back to what they value. Everything else would flow. Instead, we have all these cottage industries because we can't just bring that coordination together because it is so complex. But the technologies are there. If we can.
I think it's the people though as well, Justin, because if we did a study a while back,
of course,
one of my students did a study a while back, looking at the difficult IV lines and looking at the smart page messages that went back and forward just to get a difficult IV line done. And it was, you had to decipher the messages that people were sending each other, and you can a computer couldn't do it very easily. So anyway, it's interesting. We never published that. We should have bloody published it. Excuse my language.
I know when we put in the Integrated Operations Centre, because I was asked about it, because it's located right next to radiology, and there's a certain value to that location that you got to wonder why it's an IOC, like an air traffic control tower. And I was being asked about the value of it and being where it was, and just having to actually, on that point, Sally, just remind individuals who perhaps weren't there, seeing what we achieved when we did put it in, because it's certainly not an air traffic control tower, but what it did do in terms of achieving a culture change, which was moving away from certain individuals wandering floors with phones and all that local decision making, which on the one hand was very close to the shop floor, which you might say is great, but on the other hand was riddled with variation based on that person's intuition.
I can't see any empty beds.
Right?
There's no beds in the hospital. Yeah.
Those were the days.
That tacit knowledge that you can't articulate. Of course, it's there, but when you're as big and as complex.
I know, and it was only a very small
air traffic control tower.
Yeah, it was very small, the study we did, but it showed quite a number of gaps, and it showed the time taken, like John was saying, just to get the right patient in the right ward at the right time, what they wanted, what they needed. Anyway,
we did some analysis before when I was at Capital and Coast, because we'd just taken on Wider Upper in terms of doing specialist clinics in Wider Upper, and it turned out it was cheaper for us to put all of our doctors in a helicopter and fly them to Masterton Hospital than it was to have them all in cars driving there to do clinics. But you can imagine that would have been on the front page of the hospital, on the front page of the Dominion Post at the time.
But if it was more efficient.
Well, it was 100% more efficient. Just the perception of it being, why are you doing that? But the reality was it was definitely, and it was probably safer as well. You know, like the road over the Rimatakas is not a great road, and we put them in little tin box cars, and so we have these highly valuable assets spending more than 2 hours a day for a 4-hour clinic often. So 2 hours driving for a minimum 2 hours driving for a 4-hour clinic, and then there were sort of 4 or 5 clinics a day. So you stick them in a helicopter and save, you know,
hours.
a good 10 hours of work at $200 an hour or $150 an hour or whatever it is, you know.
I'm in the wrong job.
Definitely worth it. Yeah. So yeah, we pay them a lot of money, those specialists. And so I get your point, Justin. Yeah, you got to try and organize it around the patient, but at the same time, you have to manage that scarce resource as well, because otherwise there's kind of that. I've seen those outpatient clinics where you organize it around the patient, so the patient comes in and it's all sequenced. So the SMO goes from room to room to room to room, and there's someone trailing behind managing all of the referrals and notes and all of that sort of stuff. Because I think maybe it's valuing both of those. I think maybe, and then trying to orchestrate everything around it. I guess
oncology does that. Outpatients does it very well with their infection control stuff around it as well. I thought, well, that was just my the scheduling and things, and clustering things. That was just my opinion from watching my dad as a patient.
So in Wellington, the cancer centre did like radiation planning, but we didn't own all of the MRI and CT scanners, and so we had this problem of having to send people to the radiology to get a scan, to do the planning, to then have the clinic appointment and stuff. And so I had this great idea that we'd publish all of our clinic appointments back into the main system. So when you were then making the radiology appointment to do the MRI scan, you could then see where the planning appointment was. And funnily enough, that was half the problem. The other half of the problem was getting the radiology people to give a crap about those other cancer appointments, you know, the behavioural piece that kind of goes along with it. So
kind of comes back to that care navigator. I don't know. I've seen it work and I've seen it not work. Yeah, don't know.
Yeah, I think that's a really interesting question around that care navigator thing, because if you've done a good job designing the service, how much of a care navigator do you need? And maybe we're always going to need them, but the way we've designed the lack of design in the service at the moment maybe means we need a whole lot more than we would otherwise.
Yeah, it seems that a lot of industry that's not medical is going, well, not public is going navigator-ish, like a lot of the funding bodies and things like that. But I don't know if it's going to work.
But is that because their experience is poorly designed?
Yes, but
you know what I mean. So
how do we fix it? How do you get the influence?
Yeah.
Anyway, I'm being
designing it better. I don't know.
I'm tired. I'm a bit meh today. Sorry.
I can see we're doing a bit of conversation in the chat about money. In a blunt sense, I met the new health economist, Tommy Wilkinson, from the Ministry of Health the other week. So we started talking about money. But I read exactly the article that Ben posted about the co-payments in pharmacy. Fascinating, isn't it? That, you know, we were busy trying to gather some revenue from people that couldn't afford it so that we could, not give them the medicine, or I couldn't really understand what the logic was of trying to earn money out of people for not giving the medicine. There's an interesting concept around free goods. So
yeah, there was a bit of clawback on finding revenue somewhere. So that was the pharmacy charges. At one point, they wanted it to be $10 each. But it was one of those things, I think, was a knee-jerk reaction to fix one problem without knowing what the unintended consequences that people were therefore not getting their medicines, and that they were not getting ill and then ending up in hospital, which cost you more hospital beds, was actually more expensive. So I read a couple of articles around this. It was fascinating that actually, if you understood health economics properly and you planned for that thing, you could offset potential days in hospital by actually investing a little bit more money up front. But we again don't do that well because people constantly are trying to reduce their bottom line or save money wherever they can, particularly historically in DHB world.
Well, the costs and benefits fall in different parts of the system, so the cost, we're getting revenue out of the community pharmacists in order to cost us money over in the hospital space. And so because we're so divided in how we deliver that care, it doesn't kind of matter. And it's funny because Tommy was telling me he used to work at Pharmac and then went overseas and slowly made his way back to New Zealand. He said, in large part, the criticism of Pharmac can easily be levelled at them because their job is really to spend the money they get the best they can, not to deliver outcomes for New Zealand, if you know what I mean. So you're kind of in the situation where they do a really good job based on what their job is, but are they doing the right job is kind of the question. And so you kind of got this interesting question in that of maybe they should be worrying about some other things. And we talked about, bringing all the way back to the Therapeutic Products Bill, which I wanted to talk about at the start, and we kind of haven't even started talking about it. You've got that really interesting thing for me about medical devices being very, very different to pharmaceuticals. So pharmaceuticals you put in your mouth and it's gone, or you buy, 10,000 of them and they sit on a shelf, but with a device.
I've got a good story about that too.
Oh, do you? Will you tell us about the good story, and then maybe it'll illustrate the point.
Sorry, you say you put it in your mouth and it disappeared. So this was the vibrating pill for constipation is now available.
Wow. So it's a pill and a device.
Yes, it's both. It's a drug-free.
It's such a good slogan.
Yes, solution.
Is it a drug? Is it a pill that vibrates?
Wait one moment while I tell a story. The drug-free solution is designed for daily use. So in a trial, the pill produced at least one additional weekly bowel movement for 41% of participants. So what it is, it was approved by the FDA in August, but it's now just becoming available for prescription. It's not a drug. It's considered to be a Class 2 medical device by the FDA, which is in the same class as contact lenses. So how it works, around bedtime, the pill is inserted in a pod to activate it, then swallowed. It travels the digestive tract and reaches the large intestine about 14 hours later. So after it's swallowed, it's active for about 2 hours, goes quiet for about 6 hours, and then activates again in another 2 hours. And then it does little vibrations 3 seconds on and off to mimic the wave-like muscle contractions that makes travel through.
It's like the Pied Piper of your digestive system.
Yeah, but my interesting thing of that is, I mean, then it just exits out. So now you have a literal waste product.
Oh, is it not reusable?
No, it's not.
It's a single use.
Single use. Medical device.
I started reading about
it. Imagine the E. coli in that.
Yeah. I was thinking about, there's so my son grew up, is 14 now, and he had these hex bug things, which you put in an arena.
Yeah.
It sounds like a hex bug in a pill, is what it sounds like.
Yeah.
Oh, something else for ESR to look for in the wastewater.
Well, that's what I'm thinking. Someone's kind of got to deal with it at some point.
Because presumably not all of it's biodegradable, there's got to be a mechanical element to it, I'm guessing, like if it's vibrating. Michael's joined us at probably the most inopportune time. I think he joined us at the point that we said, and then it comes out and it vibrates. talking about the pill that's just been released for, I don't know, for increasing your bowel movements.
Yeah,
literally a mechanical.
Wasn't it by 1 a week for 41%? So it's
yeah. So it's highly effective. Highly effective stuff.
Thanks for clarifying that, John. Yeah,
we're
halfway through. Yeah,
we're going to be talking about something completely different. Yeah. So that's really interesting that it's a device. That it's not a. So it's a device because presumably it has no pharmacokinetic. That's the term, eh? Pharmacokinetic effect. Is that the term? Like it's not a pharmaceutical in that way. Yeah, it is a pill, but it's not a pharmaceutical. A little bit like the pill cams used to be. Whatever happened to pill cams? Do they still have them? Do we still use them? Do you guys still use them, Michael?
No, we had a presentation. Yeah, it was years ago now, and I haven't seen. They were quite hard to swallow. But they were trying to work on them getting smaller. But yeah, I haven't heard of them being used actively.
It's interesting because you kind of think, if that was years ago, things have got smaller in the last few, and the batteries have got way better as well, so you kind of wonder, maybe they're kind of getting there. I don't know. But so the Therapeutic Products Bill is something that's kind of, we're going to have to provide some advice to Whatu Ora, is going to have to provide some advice on it. And so you've got, interestingly enough, there's a whole lot more post-market stuff, which I was starting to say before, which is the most interesting thing. So you buy a pill, it sits on the shelf, and then you take it and it's gone. But, for these devices, you've got the, does it need maintenance? Does it have consumables? Do you need to train people on how to use it? Then, does it integrate with a bunch of other things? And so there's this interesting kind of question, I think, in the Therapeutic Products Bill, where a lot of that stuff kind of goes unsaid. And so that's kind of problem number one that we've kind of been trying to get our heads around. And in conversations we've had with MedSafe, they kind of recognise it, but they know their hands are a bit tied. So once it's in market, it's an interesting thing. The other interesting kind of question is probably the innovation thing, So either we decide to invest a lot in this, and so they can support a lot of innovation and support a lot of trials and testing things and validating things, or we don't. And so we have to rely on the FDA, or we have to rely on the TGA. And so I think you run into this really interesting problem of, if we're going to rely on them, does that mean we don't do any innovation, or do we rely on them to do that, to do it in foreign markets, which we know has a problem. So the last kind of question that I apply in that context is if there's a treatment, think about an AI that helps Māori get the right medicine for them. FDA is probably never going to approve that because they don't really care about Māori, and neither should they, because they're an American federal agency, not a New Zealand organisation. So you kind of run into that gap of, so if we're not going to have something, we're going to rely on other people. They're going to be busy authorising uses which suit their market but not ours. And so that to me is kind of a really interesting problem that we're going to run into in the next wee while if it goes ahead. I personally, I don't see it being a particular vote winner. I see from a health perspective, maybe it's a useful thing. So then I was talking to a doctor who said he feels it's a consumer rights kind of issue, or a consumer, a safer trading kind of problem. So as long as you've got good guidelines around that, I'm your clinician, you should be buying the thing that I advise you should buy. That's why you're seeing me. It's not really a problem, but then 36 hours of reading every 24 hours, I think puts paid to maybe that thought. But I don't know. Interesting question. I don't know. I can see you there, Mimi, and I can see a Medtronic thing in the corner. So maybe you've got an opinion.
No, sorry. I've just been forwarding the Teams link, so I'm just interested to see what you guys are talking about. When you talk about AI, we already started using AI, and it's all FDA approved, which is really interesting when you bring that up in the discussions. Innovation is a part of what medical devices company are big into. So interesting to your view on the pharmac side of it. I think it's all about the KPI as well that the pharmac has got. So the KPI could, it depends on how you who set the KPI. If the KPI is more towards the innovation funding, you have an innovation fund, for example, we can do a lot of benefits for people that's in New Zealand. For pharmaceutical, any device companies, I think, that's what needs to be changed.
I think that's the interesting thing is what are you trying to measure? And the interesting thing about health is, it's the long-term outcomes that are the important ones, aren't they? So it's hard to have a KPI, which is, I think, in what you were saying before, Justin, selling credit cards and mortgages. If it turns out that the house is going to get swept away in a flood in 5 years' time. So it's kind of the disconnect of that short-term kind of trying to get something changed or trying to do something versus the long-term outcomes.
I do see New Zealand has got a benefit because a lot of the other countries, for example, in Australia, it's all based on, you need TGA approval, you need CE approval, especially in Australia. So any of the pilot pilot trial that we're doing, as long as for New Zealand, for example, we only need the approval on FDA. That's how you can bring in technology to the country. If we're not allowing that to happen, we'll never be able to access to any of the new technology or innovations in other parts of the country, of the world.
Yeah, I think the other thing's true too. So strictly speaking, you don't need any certification to use stuff in New Zealand. So you need to register it on the WAN database, but there isn't actually a regulator that decides these things. So the only time I think this has actually been applied is with COVID tests. So there's a special reserve power that the Director General holds, which allows them to constrain market access to different things.
So can we leverage that to bring technology into New Zealand a bit quicker?
Potentially, yeah. What do you think, Michael?
I was just going to say, like, that's partially true. Like, so you do need to register with WAND, but you also, like, so clinical engineering departments within hospitals, I suppose, take ownership around making sure devices are safe to use, and part of the so ASNZS 3551 around testing medical devices within a hospital environment requires that it has, either CE or RTG, so have gone through some regulatory requirement. I think looking at, my worry, I suppose, is around that innovation piece. If you look at the in-house innovation, I suppose, in what we've current services that we're providing, say 3D printing, what impact's that going to have on those current services? That's one of my biggest worries. So like for us, we do 3D printing of orbits and cranial plates, for head, and that's a national service. That what's the ongoing impact for those already entrenched services that we have, but then also those barriers towards innovation, but we want to do it safely. That's where the bill's really good.
Quick question I have, Michael, is how good are we at tracking the consequences? Like, so obviously you have regulation like this to protect the public, or whatever. The one kind of example I can imagine that will be quoted in the Therapeutic Products bill was the surgical mesh thing. But of course, the surgical mesh has been approved. So it's not even in the sense that you've been using something that's not approved and it's led to this problem. Surgical mesh is like an approved product through the FDA and CE mark as well. And yet that still led to this massive problem. And so you've kind of got this question of, so you could have the regulation and still have this problem, it seems.
Yeah, I mean, a classic example of that is the leaking building syndrome. So, we've got a building code. We built lots of buildings. They were measured against, like a building code by councils, and then we've still got a problem. So I agree. So, obviously different risk class within medical devices get assessed at different levels. So, surgical mesh might be a class 1, which means it has less scrutiny through that process, but has bigger impacts if it goes wrong. So it's really, I think that's where it's has to be really carefully done around that self-certification. What does it look like? What's the impact? How many patients is it used in? And I suppose that's part of building up a regulating body, whether we adopt like what Australia has done or build our own, learning from them. But
so that was the last thing that I was doing a little bit of looking today, sort of looky-loo, and PGA has got 1,000 people in their regulator. We've got 80 people in MedSafe. That's 920 people we don't have. And so you've kind of got this question of, so 1,000 people in a regulator is probably reflective of safety more so than market size, I would have thought. We're going to use the same type of products that Australia would use. And so it's not like you can go, we'll make that 120 and sure it'll be grand. And they've got a
really like paperwork.
Well, I'm sure they do. Safety first.
I'm wondering how you stop individuals importing stuff, patients importing stuff.
Well, that's the problem the US has at the moment. So they have that problem with medicines. Import medicines from Canada. So yeah, it's a really interesting problem. I assume assume you'd have to find a back alley surgeon if you were looking for an imported implant or something. It's like, hey, I got this thing on AliExpress. Can you put it inside me?
No, seriously, my friend imported blood sugar monitoring stuff and made his own blood sugar monitor hooked up to his phone from AliExpress.
You could just buy blueprints and 3D print your stuff for you in your garage.
So, true. I was wanting to pick Michael's brain sometime about 3D printing.
Yeah, feel free to drop me an email. Yeah, happy to discuss that.
I've got a project printing guide dog harness components, but it's been on hold because of all the redundancies at work, which aren't happening now because they did it wrong and have to start again. But that's another story. But the bioengineering lab is finally going to pick it up in a couple of months, so it'd be kind of interesting to get someone who's 3D printing in health's opinion.
Brilliant. Yeah, no, definitely. Yeah, drop us a line, Sally. Yeah.
Shall do. What's your email? Can you flick it to me?
Yeah, I'll drop you an email or connect in through LinkedIn.
LinkedIn.
Yeah.
Is that David
Should
White's
be in the
group,
appointment
Sally?
today. So.
David White, yeah.
Nice. Yeah, we talk to
so,
David White all the time. So.
Yeah, I thought he was going to take redundancy, but he seems back.
He's back. No, he's back. He's awesome. His lab's awesome.
I know, I love him to pieces. So. He's awesome. But we were going to do it last year and then they announced the redundancies and it's like, oh crap.
Yeah.
So while we're busy satisfying our own personal curiosities, so I've got a question for you, Michael, around the laser cutting side of things. So do you guys do much of that side of things? Laser 3D etching and cutting? I saw your etcher, but
yeah, we do etching of a surgical instruments for identifying, but any outworking cutting we get done by an outside company. So we do the design, but get it outsourced.
Okay. So not laser cutting as part of your surgical process?
No.
So what other
I was
things?
looking at CO2 lasers versus fiber lasers on the weekend for cutting steel. So
right, have you thought about water jet cutting for steel, because it's a lot safer?
Yeah.
Wow.
Safer. You know, but possibly
planning,
less
John?
exciting. You know.
What evil are you planning?
Sorry, what am I planning on cutting?
No, what evil are you planning on cutting?
Oh, no. So I was looking at manufacturing some things, and I wanted to manufacture them out of, I don't know, maybe 5 mil steel. They're small things, and so obviously, and they need to be robust. And so I was thinking about doing it that way rather than, because you can now get sinter laser stuff for metal 3D printing. And I was trying to figure out which was the better model. And it seems like if you're going to go volume, doing the 3D, doing the laser cutting side of things would be a much better option. So it's not like call it almost like an extruded 2D part that I was thinking about, rather than a 3D model almost. That's why I was going with the laser cutting idea. So
yeah, it comes down to material strength and stuff like that. Yeah, like that integrity. Like 3D printing's still got weaknesses. Yeah, but there's downsides to heating, obviously laser cutting. So
yeah, it's not. I'm not going to hang off a cliff via a carabiner I've cut, but it's.
And you're not going to swallow it.
No, it's not for the latest generation pill cam. Vibrating pill cam. Yeah. Very good. So yes. So
you guys have been
anyway,
thank you.
we're gonna have to try and figure out what we're going to say about this therapeutic products bill, because I think there's a bunch of wrinkles in this, and the John Herry suspicion of this whole thing is it might get killed, because I don't think anyone's going to vote for the Labor Party if they push it through. And I figure, like, it feels like maybe the National Party would make a big song and dance about how complicated it is and how hard it's going to be, how much money it's going to cost. So,
I think I missed that part of the conversation.
The therapeutic products bill.
Oh, no, I didn't. I just didn't hear what you said properly.
So my suspicion is it might get killed because it's too hard, basically.
Yeah.
Seems like it's too hard. There's too many things to figure out. And it's going to cost lots of money.
Lukewarm post-election.
Yeah. They'll basically say, we'll make it after an election thing. And of course, Te Whatu Ora isn't in control of this, so I suppose we're kind of just people that'll have to give an opinion at the same time.
Yeah. Is it the ministry driving it, or is it DPMC?
I think the ministry did the early work on it, but it's going into select committee, so they're getting feedback on it at the moment. So, yeah.
I mean, about that kind of stuff, putting bills through Parliament. Who's good to talk to? I need to learn more.
I can send you a link to the web pages are quite good, and they've done the videos of all of the first readings for the therapeutics bill. They're quite useful to.
Oh, not just the therapeutics one, in general, getting things through Parliament, because people kept telling me I should get involved in trying to fix Waikaha's stuff.
Well, I think at that point either you take a political route or a policy route. So political route is you become a member of a political party.
Lobby group.
Or a lobby group, and then the other option is you there'll be like external consultation stuff that the Ministry for Disabled People will run, and I would even just send them an email.
I have been. Believe me, I have been. It's not just me.
It's worth looking to see what bills
but I want to know the process
in submission.
Right.
You can go directly to when it goes to Parliament rather than going through the agency that's pushing it.
Yeah.
Because I was talking to someone the other day and they said, I want to put you in front, because I was pulling something to pieces, and they said, I want to put you in front of the select committee. I'm like, do I really want to? So I need to figure
you're kind of in the ideal job for doing that. So often the people that end up going to select committee are people that are researchers or are people that are advocates or, lobby groups or private sector. And then because the government agencies put their advice through policy documents. So,
sanitation process.
Yeah.
Sounds like a toilet.
So there's a process that gets put through to generate the policy. We think there should be law around this thing. That then goes to the minister and goes to cabinet and then gets on the schedule. There's then someone that you then put together, and I know all this through the COVID stuff. You then put together drafting requirements for the cabinet law office. I think they then draft the law. You then review it to check that it's right. It then goes for a first reading, then goes to select committee. And then as part of the select committee thing, often you get public consultation, and then it gets goes to the Parliament again for second reading. And once it's second reading, then it gets enacted on whatever the date the law is that's allowed to be enacted. And then there's a bunch of advice going in from us on a government perspective to go, if this goes through, here's kind of the operational consequences of making that decision to vote for that thing.
But people who make submissions are often invited to those select committees to talk about why they said what they said in their feedback, or to do a bit of a deep dive.
I've given feedback to a few things online,
and then
never heard back, basically.
And then also there are standing select committees as well. So like there is a health select committee, and their job is to scrutinise the spending of the health system, if that makes sense. Yeah, doesn't meet the legislation, like the requirements under the Act. So,
but are the requirements in the Act correct?
Well, but that's
sorry, I'm just being a bit.
So there's a little bit of the Law Commission does some of that work as well. So I don't know if you've heard of them. So they do some of that work to ask the question: does the legislation match the requirements of the day? And so sometimes bills come through that. But also then they have the backdoor one where they all put their favourite stuff in the tin.
Oh,
and they draw random stuff out of the hat.
And I thought that's how it happened for all of them.
Oh no. So most of it comes through like campaign commitments or policy commitments, which then get instructed out to the government to go, hey, we need you to start working up the policy for this bill, which will come back to cabinet to get approved. Does that make sense? That's kind of the roundabout, is mostly through government policy process, but then with the select committee as well, often incorporated in it. That's about right, hey, Eileen?
Yeah, that's about right. Next time you're in Wellington, you should do the free tour of Parliament. They're quite good, the educators there.
It's interesting. I've never done it. I've never.
Yeah, you should. You should. It's really interesting.
And it is free.
When do I come to? I got invited to something in Wellington, but then they were supposed to invite me to the Auckland one. I didn't want to fly down there next week. Next time.
Oh, are you coming down to Diana's thing on Thursday?
Diana Rogers.
No, Diana Rogers. Bonus you.
No, I'm not. No, I got invited to somebody else's thing down there, but they meant to invite me to the Auckland one, but they invited me to the Wellington one.
Oh, okay.
So it's like, oh crap, okay.
Diana
Sue, what's
Sue's
she
going
doing?
to see the minister. So she's going to see the minister with the CMDT people. And so I'm going along because I'm on her advisory group. I think Eileen and Mary, did you get an invite as well?
Yep.
And Ben.
I meant to actually contact her about something and I can't even remember what it was.
Are you coming, Michael?
Yeah, I'm coming up. Yeah.
Oh, cool. Are you around in the afternoon then when you go home?
Yes, yeah, I'm around in the afternoon. Yeah, I'm heading back about 6 o'clock, I think.
Oh, cool. Well, so we'll obviously be around. Do you want to come to us and for the afternoon?
Yeah, that'd be cool. Yeah, I was going to look to catch up with people while I was up there to make use of the because it's just half day thing, isn't it? So make use of that time.
It's in the morning. Yeah.
Come hang out with the cool kids.
Yeah, come and hang out with us in the
Brilliant.
office.
Okay, that sounds great.
Have you guys moved yet?
Yeah, we have. So we're now in the Spark building, which is on Willis Street.
Oh yeah, I know Willis
Spark
Street.
Central is what it's called. So yeah, level 5 Spark Central.
Is that different to where Eileen, where we went for the 3D printing thing? You've moved since then.
Yes.
Wow.
Yeah, well, it's all excitement. It's all go.
Okay, that's cool.
Whole new building, whole new life.
Exciting.
Yeah. Righty ho. Well, we might call it there because we're after 5 now, and people probably have to either go and cook dinner or go and do other stuff. So
don't have a nap.
Yep.
That's so
have a good evening.
Thank you all.
Nice to see you.
We'll do this again in 2 weeks. Cheers. See ya.
Great to see you all again. See ya.
See ya.